sponsor reviews. We these are today's folks are sponsor, but it has.
Good morning, everyone, and welcome to our John Jane series. And okay, great, Jens, you're here. Perfect. This morning we're going to have Rob Eastlack give a talk on deformity, and Jens Chapman is going to introduce Rob.
One second. Good morning. Trying to make sure. So I had to switch modalities. I love the outfit. Dr. Eastlack is a wonderful speaker for our John Jane speakership. I couldn't think of a better person to talk to us and educate us about segmental instability. As a matter of background, Dr. Eastlack is a national, internationally renowned spine surgeon, and he deals with all complexities of the spinal column, from deformities to oncologic conditions to complex revision situations. His background is that he went to Texas, Baylor School of Medicine. He did his residency at UCSD, and he did his fellowship at the Mayo Clinic. So he's had a all-around superb education. He's one of the vocal lead members of the ISSG, which has changed the way that we quantify and understand spinal deformities. He has well over 200 publications. And again, he is a national spokesperson. And we're very interested and honored to have you here today, Rob. In terms of the thought of prevention of deformities and understanding of deformities, and how much and if and when where we should try to correct them surgically. So thanks for doing this, and really interested to hear you talk, and we'll have many questions, I'm sure.
All right. Thank you very much for having me. It's a pleasure and honor to be here today. Let me share my screen. So the goal of today was to really go through what we've started to turn our eyes towards with respect to degenerative spine, as we've learned much more about the spinal balance, alignment, and compensation, reciprocation phenomena with deformity, and really trying to prevent the deformities from happening in the first place that obviously could be somewhat catastrophic to try to manage. The objectives today will be to reinforce what we know about sagittal alignment globally and regionally, learn a bit about this concept of segmental compensation, which is relatively new, and then identify means of assessing and targeting the appropriate segmental alignment when we're reconstructing. And just to kind of wet your noodles on why this matters, this is sort of a famous case shared across the land about a young nurse who had an initial decompression and then a fusion surgery, and goes on to have multiple surgeries. And you can see here the early fusion outcomes radiographically, then goes on to fail above that, has more surgery. Then you see this iterative difference in technology used and good fusion accomplishment. But as you see this litany of surgeries go on through these different imaging sequences, today, a trained eye will see that maybe alignment wasn't really tended to. And so, unfortunately, many surgeries later, somebody looks at spinal pelvic parameters, and you see here that she's woefully managed in the lumbar spine with respect to normal alignment, and that leads to ongoing failures. So what do we learn from this horrible case in a young person gone awry? Well, that the risk is multifactorial, of course. There are certain things we can't modify, age and genetics, and the stiffness of a fusion mechanically creates a problem that we cannot necessarily circumvent. But there are definitely modifiable issues such as muscle weakness, sarcopenia, muscle damage during the course of surgery, and it turns out alignment. And it's not just for deformity. We'll go through that. There's a lot of history and great minds that have gone into determining why alignment is important. Dubuisset created the cone of balance theory, and then really gave us sort of the foundation for understanding this and understanding what compensation really was all about in terms of trying to stay in this cone of balance. and that the deviation resulted in an increase in muscle and energy use. And really, when out of balance, an unfortunate climb and disability profile. And from that work and a lot of other radiographic assessments, we started figuring out that there were certain areas to look at that were more meaningful, such as the pelvic incidence and its relationship with lumbar lordosis as one of the most important parameters of determination with respect to reported outcome measures and disability profiles. Global parameters such as sagittal vertical axis or T1 spinopelvic incidence, that was also quite important. And then compensatory maneuvers or mechanisms like pelvic tilt, not the only one, but one of the important ones that really helps accommodate these out of whack alignment issues that occur in the spine for one reason or another. So these are the parameters we learned about early on, and we'll go through why those are important and how they relate now to focusing in on degenerative spine care and segmental alignment. And this is something that I'm sure you have all heard and often comes up. If you're just doing degenerative spine and you decompress the nerves and the patient feels better, why do we care? And the reason is because the spine, despite the ability to compensate, probably has some negative ramifications if we don't reestablish normalcy where we reconstruct, even if it's singular segment. And so the old adage of there are spine surgeons who fix deformities and those who create them is likely quite true. So what can we learn from all that deformity principle work when we're caring for degenerative spine? The alignment considerations are global, they're regional, but they're also segmental. And so we want to understand how each of these segments and each of these subregions and regions affect their neighbors. Some of this work has been done on the deformity patients, but understanding how individual segments or subregions actually can have pretty profound impacts on the whole. And when you study it in deformity, because you're creating a very large area of stiffness and you disallow as much compensation to occur, it often has a more profound and early impact than in the degenerative state, but it's still something we can learn from. So this more recent study that we've done in the ISSG, we were really looking at segmental or subregional normalcy. So we took the patients that we have managed surgically for deformity and looked at the adjusted segmental lordosis relative to pelvic incidence. And normative values were determined, and they were either assigned over prescribed matched to normalcy or under prescribed in terms of normalcy. And you could sort of see here in this table with respect to the pelvic incidence on the left, and as the pelvic incidence climbs, how the normalcy of the segmental lordosis tends to climb a bit, while there's still a lot more climb in the upper lumbar spine, but still some climb in the lower lumbar spine. And if you looked at that group of patients, when we overprescribed lordosis in the lumbar spine or underprescribed it, we had greater failures, higher rates of PJK and PJF. And the pertinent areas were in the thoracolumbar spine and then at L4 to S1. So those were really critical areas. So from that, one of the things to take away is that the lower lumbar spine is a much more critical player in not just deformity, but probably degenerative spine. And we'll talk about why that is. There's just an example of the undercorrected and overcorrected cohorts relative to the middle group, which is matched, and then the impact on patient-reported outcome measures as well. So let's go on to the shorter regional reconstructions. Dominique Rothenflue has done some amazing work out of Oxford on this concept. And this is starting to look at when we do degenerative spine and we're not attentive to apparent deformity in that region. So you may look at a patient and say, hey, they look great. They stand straight. I don't see any deformity from a clinical visual perspective. But if you don't look radiographically within the region that you're working to understand if there's some hidden deformity that's being compensated for, you can still get yourself into trouble. And Dominique's group out of Oxford looked at that very issue. They took 49 patients that required revision surgery after 1 to 3 level fusions against 39 controls. And it was pretty astounding. What they found was that there was a 10-fold greater increased risk of requiring adjacent segment disease surgery if there was a 10-degree mismatch or more between pelvic incidence and lumbar lordosis. So if you're seeing a patient that is mismatched between their lordosis and pelvic incidence, meaning they have a hidden deformity in their lumbar spine, and you fuse them even with 1 level, you are prescribing them to a considerable additional risk for future surgery. This was looked at again in Japan and Matsumoto's group, and they also found that there was a higher risk of adjacent segment disease with a preoperative index surgery in the context of pelvic tilt abnormality, SVA abnormality, or a greater mismatch than 10 degrees. So again, hidden deformity not attended to. And this was all, as you know, in Japan, very commonly posterior lumbar interbody fusions with really no change at the levels that they were working at. So they didn't really adjust the segmental alignment when they reconstructed. Zach Temple and Adam Cantor, David Okonkwo out of Pittsburgh looked at the influence of this mismatch concept in lumbar lordosis, and they were doing T-lifts at L4-5 or L5S1, so these critical areas at the junction of the lumbar and sacral spine. And they found more quantitatively that for every degree of increase in the mismatch, there was a 1.3 to 1.4x increase or times increase in surgical level adjacent segment or surgical required adjacent segment disease. So again, giving you the sense that you've got to look for those hidden deformities and attend to those, even if the patient clinically seems to look okay to you from outward appearance. So there's your numbers, and so let's boil this down. So should we care if there's no mismatch? And that's where this concept of not just global compensation comes from, but segmental level, regional compensation. So you see this patient on the right, and what we want to get to here is this consideration that there's a biomechanical impact that occurs when there is a lack of normalcy and there is stiffness in the spine around the area of fusion or subadjacent or superadjacent to that, because there are changes in shear forces and compensation mechanisms create some stress on the adjacent joints. Jay Turner at BNI with his team and Brian Kelly in the lab there looked at that concept in a cadaveric model. And what they found was that when they took the L4-5 segment, as you see here on the upper right, and they fused it either in a neutral position, a lordotic position in relative terms, or a kyphotic segmental position in relative terms, they had they used different loading mechanisms that simulated gravitational loading. And what they saw was that there was both a 50% increase in the strain at the L3-4 disc when the patient was in a relatively kyphotic position at the with the L4-5 level fused. And in addition to that, an increased level of motion at the L3-4 level. So you're seeing at least in a biomechanical cadaveric model here that there are prices to be paid at the adjacent levels when an index level is fused in a suboptimal position. This is also work that Dominique Rothenfleu's team and Marco Centelar did out of the Oxford lab. And this was in FEA, or finite element analysis, and they looked at the L4-5 fusion in situ versus kyphotic versus lordotic. So similar concept is the cadaveric model that I just shared with you from BNI. In this case, with the FEA, they found that with a kyphotic condition at L4-5, relative kyphotic, there was a 29% increase in shear forces at L3-4, while a lordotic condition had a nearly 40% reduction in the shear forces at L3-4. So important to consider those two pieces of basic science sorts of data and how we handle degenerative spine, understanding there are implications for the adjacent levels. So what are compensation and reciprocation? Let's just go through those briefly to make sure everybody's on the same page. There are global compensatory mechanisms that we see frequently in deformity. And those are things like pelvic retroversion, so that the hips will swing under, the pelvic swings under, to reduce what you see as an SVA. If the patient's sort of stiffened and they're falling forward, they will flex their knees, roll their pelvis under to help bring their head back to a closer to normal pelvic plumb line or hip plumb line. There is also thoracic hypokyphosis or thoracic lordosis to compensate for a kyphotic area below. And that all allows the SVA, as you see on the right, to swing back, and for the plumb line, which the nervous system likely wishes us to have to be in better harmony. And then there are muscle requirements to do this. You see on the right, the flex knees and the flex hips. All of this creates a fatiguing mechanism in the sagittal plane. You can also get cervical or occipital cervical hyperlordosis, as you see in the picture on the right. And at the end of the day, there's also regional and segmental compensation. So in addition to things like thoracic kyphosis and compensation and reciprocation, we're likely seeing segmental compensation, reciprocation occur. And I'll show you some examples of that shortly. This is some early work that was done with Sig Bervin and his team out of UCSF. And they were looking now, one of the early looks at segmental fixation and what that created. They did 1 or 2 level fusions here. And the important thing, I think, to glean out of the work that they did, because they only had a 12-month follow-up, so they really couldn't look adequately at one of their intended endpoints, which was adjacent segment disease. But what they did see was that at the upper level, the level above their fusion, they actually had an increase in lordosis, which subtends that supposition that we probably are seeing compensation occur if we don't get it right at the index levels. So here's an example of, on the right side of the screen, a patient who has pars defects, a spondy with a listhesis at 5-1, and you can see a complete loss of the disc space, presumably a loss of L5S1 segmental lordosis. So if you look at that picture and then you do the measurements, and you can see those over here, you realize that the pelvic incidence lumbar lordosis are actually quite well matched, right? Why is that? You probably have a natural 15, 20 degrees of lordosis at L5S1, and yet there's no mismatch. That has to be occurring through a mechanism of some compensatory maneuvers within the lumbar spine. And so that is an example of where compensation likely is occurring. You can see it here as well with a relatively flattened L4S1 region and hyperlordosis of the L3-4 level. So you get hyperangulation, you get extension. In the upper lumbar spine, this likely provokes some retrolisthesis and then increased posterior element stresses. And disc shear forces obviously can occur in both with ventral or dorsal vector. So all of these undesirable impacts can occur. So take this same patient, 58-year-old woman with a long history of back and leg pain. She's failed non-operative treatment, and let's go through this exercise of evaluating segmentally. And if we do that, what you see is the match that I showed you, the pelvic incidence limb lordosis are about the same. But if you measure out the intradiscal angles at the lower two levels, you see about 3 degrees, if that, at L5S1 and 22 degrees at L4-5. Is that normal for L4-5? Well, probably not if you look at the data, and we already have surmised there's likely some sort of regional compensation going on. And so we prescribe a more optimized segmental alignment at L5S1. And you can see here we've changed that now to 16 degrees. And in follow-up, you see a softening of the lordosis segmentally at L4-5. That is essentially a reciprocation at a segmental level when appropriating normalcy of alignment at L5S1. So it's dropped now to 10 degrees. If you look at compensation reciprocation in a more study-like format, we took at our institution about 50 patients at undergoing L4-5 or L5S1 single-level fusions, and captured patients that actually were undergoing an intended normalization or increased lordosis segmentally at the surgical level of more than 5 degrees, but had normal baseline lumbar lordosis relative to pelvic incidence. So these are patients that we presume are compensating within the region and yet have a segmental deficit at the level intended to undergo surgery. And then we looked at their adjacent levels, both preoperatively and then postoperatively out to 1 to 2 years. And what we found was that at L4-5, when we changed on average the index surgical level 10 degrees, there was a reciprocation at L3-4 of about 4 degrees. And that continued out to a year plus. At L5S1, it was more impressive. We changed the average segmental lordosis surgically about 13 degrees, and the reciprocation at L4-5 was a respectable 14 degrees. So there's a significant compensation that seems to be going on preoperatively during the pathologic state that we allow reciprocation to occur at through follow-up. The next steps for that sort of study obviously are to not only increase the subject number, perhaps have an inclusion that's more aggressive in terms of the amount of correction generated at the index levels, and then follow them for an extended period of time to start delineating the negative impact on surgical level adjacent segment disease and its variants. So case example, here we have a 54-year-old gentleman with bilateral leg pain and back pain, has neurogenic claudication, has some weakness and a list forward posture, not tremendously list forward clinically, but certainly something to be wary of, and has a history of a 2-level fusion and laminectomy in situ at L4-S1. So in the past, no long films, no radiographs with femoral heads taken to measure these parameters and prescribe the appropriate realignment, and undergoes this minimally invasive lateral surgery, fuses well, has improved leg pain, unfortunately continued back pain, limited standing and walking tolerance, and when you pan out, clearly sagittally not very well appropriated in terms of his lumbosacral relationship. So kyphotic now from L3 through S1. And you can see here the mismatch. And unfortunately, probably as we talked about, not just the stiffness, but extra shear force on the disc above, increased posterior element stress, and rapid breakdown. Now he's got adjacent segment disease. Would that have been avoided with perhaps a little wiser realignment through L3-4? Perhaps. But the learning point here in general is the yesteryear concept, I think, of, hey, it's a single level problem. I'm just going to fuse it. He'll do fine. Is good for a little while, but it may not have a durable outcome as we wish for. So what are the keys to planning? You have to have radiographs that allow you to do at least some basic measuring. And that is at minimum the femoral heads and seeing the entirety of the lumbar spine, so you can identify the constants and the foundation for your decision making on the regional lordosis alignment targets as well as the segmental alignment targets. If you have the means to get longer alignment films, that can be helpful in certain circumstances, but the basics are being able to measure your PI and LL. And then once you have that, you want to parse those patients into the more at risk or less at risk patients. The higher risk patients are generally going to be the high pelvic incidence patients. Those patients tend to have much greater risk of failure if you don't get it right at the base, in deformity and likely in degenerative spine. So L4-5 compensation here. And again, reciprocation. These are the concepts that we have to be thinking about. And we want to be thinking about looking at the pre-op, deciding what we need in the intra-op, and then making sure that what we prescribe has a durable capability of holding the patient in that alignment. If we are doing surgery that looks great on the table, but post-operatively they subside, they fail to retain the lordosis that we had intended to achieve at those index levels, then we probably are going to submit them to the same less desirable outcome in the future. And here you see again the reciprocation after an attempt at trying to regain some of the general lumbar lordosis through an L3-4 adjacent segment disease surgery and the L2-3 level reciprocating. How do we decide now what the proper or normative target alignments should be? Lots of work has been done on spine shape and segmental alignment. This is some of the landmark work done by Rusoli and his team, 160 normal subjects, and analyzing spinal pelvic parameters. And with that work, we've started to understand how the lumbar spine tends to look within these morphologic spectrum of shape assignments. So type 1 on the left, you have an arc of lordosis that's a bit more in the upper, and the apex is around L4 there. And then, I'm sorry, L5, whereas L2, you start seeing the apex climb. And as the sacral slope goes up into type 3, your apex continues to climb. It's now up at L4. And you see the lower arc of lordosis becoming slightly more substantial. And then type 4, where apex is around L3, more lordosis in the lower lumbar spine or from L3 to S1. So understanding the shape of the spine is an important consideration for how we manage the even degenerative spine. We want to set these patients up to allow for the shape to be accommodated through any sort of reciprocation mechanisms and not overprescribe it, but certainly not underprescribe it when we're reconstructing. What they found was that with these shapes and with the study of those asymptomatic individuals, that the upper lumbar lordosis was largely constant at 20 degrees, while the primary variance seemed to be in the lower lumbar spine somewhere between 30 and 50 degrees. So there is a variance you need to accommodate with reconstruction, and again, higher risk in the type 4s more than likely. So determining normalcy, think about shape, think about apex, think about where lordosis is more substantial. From that work, Rusoli really popularized this approximation concept of 2/3. About 2/3 of lumbar lordosis seems to be present at L4 to S1. It's a loose rule, but it's one that allows you to sort of work a little more nimbly and not have to get your calculator out. We'll go through some of those equations in a moment, but if you use a 2/3 rule in general, it'll keep you out of some of the more extreme trouble. And you can even boil that down into 2/3 of L4 to S1. So you can take the L4 to S1 segment, what you would expect for normalcy, and say L5 S1 should be 2/3 of that number. So it can actually be drilled down even to a single segment level. This paper talked about lumbar lordosis morphology correlating to pelvic incidence. Similar concept where you see with very low PI, the proximal lumbar lordosis is a little bit less, and in the high PI, it goes up a bit. It's a little bit different than what you saw with Rusli, where it's fairly constant upper lumbar spine. And then there's a little climb here consistent with Rusli's work that states that the pelvic incidence that is high generally is going to mean higher lordosis from L4 to S1. So when you talk about low PI, low pelvic incidence, you want to be thinking about that in terms of lower lumbar lordosis apex, meaning L5S1, and a flatter upper lumbar spine. So the apex for, say, a type 1 Rusli patient is L5. So you want to really crank on the L5S1 level in that patient and maybe be a little less aggressive at L4-5. And the other area where this becomes important for us is when you have a low PI patient, you want to be careful about adding lordosis in the upper lumbar spine, L1 to L4. So lateral work, for instance, lateral interbody fusions, which we've done a great deal of, can really be problematic, particularly in the low PI patient, because you end up creating a lordosis that is non-physiologic, non-normative in the upper lumbar spine, and you create a proximal junctional failure risk or adjacent segment failure risk, even with short segments. If you have a very flexible spine below that single segment at, say, L1-2 or L2-3, that's a little bit different because they can compensate below. Point is, the shape of the spine has to be tended to. So in a lower PI patient or a Rusli 1 patient, as an example, and you're thinking, I'm going to do a lateral for a degenerative reason, be thinking, I want to neutralize that level. I want to keep it normative. I don't want to throw a 15-degree cage in at L2-3 or L1-2. That's probably not the right answer. Still working on how to figure out segmental alignment and how to prescribe it. This is work that was done in a similar fashion on what's called the lordosis distribution index when doing short segment lumbar spine fusions. And this is trying to get more quantitative, if you will, looking at global lordosis on the right here and its relationship and ratio with L4 to S1 lordosis. So you basically create a percentage or ratio between the two. And what they found when they used that sort of equation and its relationship with postoperative requirements, you see here that that you have the normal patient, meaning the patient whose ratio is about 2/3, so 50 to 80% of lordosis is in the L4 to S1 region. Their revision rate is 6.5%. When it is overprescribed or underprescribed, much higher, and it's worse for the kyphotic group, the hypolordotic group. So if only about less than 50% of lordosis is achieved between L4 to S1, you see almost a 20% revision rate at 1 year, and it climbs from there, although not statistically significant with the numbers they had. So meaningful stuff with respect to how this pans out for future risk to the patient. The predictive formula here of ideal lumbar lordosis and lower lumbar lordosis determined by individual pelvic incidence, and this was in elderly population. You can see all the numbers over here: upper lumbar lordosis, middle lumbar lordosis, and lower lumbar lordosis, which essentially is L4 to S1. And what they found was this concept of L4 to S1, which is the triple L, met out with these results. The correlation was higher for pelvic incidence in lumbar lordosis when compared to overall lordosis. So there's a bit more relationship of L4 to S1 and PI than the overall lordosis. And they used this group of patients that was largely singularly ethnic, and that's one of the issues, and we'll talk about that in a minute. But they came up with these equations to try to better identify quantitatively what L4 to S1 should look like. And you can see here the equation of ideal triple L, where L4 to S1 is the bottom equation. So it's a way for you to punch in numbers and have a sense of what to target for those levels should you be fusing them. Lumbar lordosis index maldistribution resulted in an increase in pelvic tilt. So if you didn't get that right, then the pelvis is going to swing under and try to help compensate. They would have a higher likelihood of mismatch between overall lordosis and their pelvic incidence, and reduced global lordosis. So taking that another step forward, the Wayne group here looked at restoring theoretically optimal lumbar lordosis that had been deduced from pelvic incidence and thoracic kyphosis. And this is in the deformity population, and found that this, with using the equation you see on the top here and determining ideal lumbar lordosis, that if they got it right, then they'd have a considerable drop, almost 55% mechanical rate complication versus 20% in the group that was ideal. So a meaningful complication difference with deformities for sure. Now, this is more recent work that Mike Kelly did, and this is multi-ethnic, so maybe a bit more representative, and almost 500 patients. So a very good look into how we understand normal alignment. This was a bit more intended to look at it from a deformity perspective, but it gives us some insight into how we should think about degenerative spine. And they excluded any patients with degeneration or deformity. So these are truly asymptomatic, normal subjects to get a window into what normal is supposed to be in general. And what they found was that, interestingly, and this is a little contrary to what some of the other papers that we just reviewed looked at or found, L4S1 was not substantially related to PI. There was a low correlation, and you can see the scatter here. There's a lot of scatter. So there's an R squared, but you can see there's quite a variance in there with PI, and so what that tells you is that you're gonna need to essentially, when you do deformity, probably keep L4S1 in a little bit of a tight corridor, probably 35 to 45, somewhere in that neighborhood. When you do degenerative, you have a little more flexibility because of compensation, but you don't want to stray too far outside that. They also found that when the pelvic incidence rose, so we're going into Russley 3, Russley 4, high sacral slopes, there would be an increase in lumbar lordosis a bit more. So a little bit contrary to what we had seen, but still affirms that there's a variance for L4S1 where we do most of our degenerative work, and you need to be thinking about keeping it in the realm of normalcy. Like I said, 35 to 45, probably 2/3 rule is not too far off from being accurate most of the time, but these are the sort of take-home equations that you can deploy to try to hone in on the right numbers. Ideal lumbar lordosis, 60% of pelvic incidence plus 30 degrees. Good number to keep in mind. Ideal L4 to S1, 25% pelvic incidence plus 28 degrees. And then, of course, I already mentioned this before, the Rousseli 2/3 rule, 2/3 of the L4 to S1 area or lower lumbar lordosis should be occurring at L5S1. So think individual segmental normalcy when you start reconstructing and fusing the spine, even down to the single segment. So in summary, segmental compensation may be in effect to maintain lumbar lordosis. Don't think when you look at a radiograph preoperatively, hey, they've got a good lumbar lordosis relative to their pelvic incidence, everything's hunky-dory, I really can do whatever I want. Not necessarily true. Why is that? You have to be thinking about how individual segments, subregions, are compensating to allow the region to be in normal state. And then failing to normalize each of those segments is likely going to lead to shear forces that are undesirable, less well managed for the disc and the posterior elements, likely leading to more aggressive and earlier failure of those segments, and potentially even leading to poor early outcome because the compensatory mechanisms that are occurring are likely occurring at the behest and as a result of multifidus strain, the stabilizing musculature in the back that has to create that compensation is likely undergoing supraphysiologic loads. They're having to generate forces that they may wear out from. So standing tolerance, mobility tolerance may be undermined by those drivers, the motors of the compensatory mechanisms in a state of non-normal adjacent segment stiffness from the index surgery. And then you want to plan lumbar reconstructions with that segmental normative value in mind and realize that what you're doing, even at a singular level, can have profound short-term, mid-term, and likely long-term implications that we all obviously want to avoid. Thank you very much. So I left a little extra time for questions, but hopefully that was a foray into segmental compensation and reciprocation that's a bit novel for you.
Outstanding. Thank you. Accept a virtual applause. Really thorough and impressive review of the metrics and the physiological understanding of spinal deformity. Let me back up a little bit into a bigger realm. Are we looking at a growing problem of fusion disease, where fusions are done with an increasing levity and lack of true full understanding of the spine? With the newer technologies of less invasive surgeries, it seems that in my clinic, at least, I see more and more patients where I go like, wow, there was a lot done to this patient. And these surgeons frequently don't even have the first beginning of basic numbers like SVA, but there's a lot of hardware in there, and I see a suspicious amount of L2 to L5 or L3 to L5 anterior, anterolateral, and posterior fusions done. So are we seeing an increasing overuse of fusions in addition to a lack of basic understanding of spinal physiology, and that includes alignment? So I'll just open this with a very generic question.
Yeah, I think you're right. I think we've gotten, because of our technology, minimally invasive surgery, whatever has led to it in that arena, I think we're doing many more surgeries than we used to do, including into the older patient population. And so there is a much higher prevalence of fusion work that's being done, where in yesteryear we weren't medically allowed to submit patients to that degree of surgery. And with that has come, unfortunately, I think, these unintended consequences. So as I mentioned in the talk, we have surgeons who are well-intended. We're managing stenosis, we're managing reasonable things to try to address patients' symptoms. But the minute we stiffen the spine, and certainly with deformity, but I think also in degenerative spine, we are, it is incumbent on us to be thoughtful about what that fusion actually portends for the patient in their lifetime. And they all are aware, every patient I meet is aware of this concept of adjacent segment disease. But it's sort of simplified into, well, you got a fusion. It's not just the fusion. There are many other factors, as we talked about. It's a multifactorial issue. As surgeons, we have to do our jobs well so that we at least limit the factors that we can that are modifiable. And that I think that's good stewardship for the patient.
Open the floor for other questions. Otherwise, I have a plethora of further questions.
Hey, Rob, I have
Yeah.
a quick question, just going based on, again, I mean, I think, there's been a lot of work done in deformity in the last, 20 years, and kind of piggybacking on what Jens said, my concern is that everyone is fixed on these numbers, right? And, if you start applying these numbers to all the 70-year-olds in our clinic who are, sagittally imbalanced and all these other issues, is that, first of all, there's the economic considerations, and I'd like for you to talk about that because, I don't know how it is in San Diego, but, Medicare basically doesn't pay for these surgeries. So how do you justify and how do you rationalize in the current environment, let's say somebody or let's say a group of patients who have these spinal deformities, because in our health system in the Pacific Northwest, we see people, Jens and I see people all the time where the first surgery they have is an L2 to pelvis, okay?
Mm-hmm.
And these are in like 75-year-olds who have sarcopenia, osteoporosis.
Right.
I mean, you name it, and you're like, geez. And now they've developed PJK, compression fracture above the fusion, and most of my practice, I don't even see de novo cases anymore. It's like Jens and I are just seeing it with a mirror. We just see people that just get fused right off the bat without any, consideration about, okay, what's the long-term consequences of fusing a spine?
Yeah, well, those are obviously big issues. I mean, you
Yeah.
got to unpack that into several issues. One, was the indication even do a big fusion correct? I think there's probably part of that problem.
Mhm.
And then the other is, even if you have a crisp indication, if the patient does have the need for any fusion, we have to do it well. And whether you do it perfectly or not will have some substantial bearings on their risk. If you do an L2 to S1, that's a deformity, typically should be a deformity operation. And the numbers are astoundingly different in terms of mechanical complications if you don't do it well and do it with numbers that we talked about. I think where we've been missing in a much more widespread way is the single level fusions. And when we see older people, I'm much more minimalistic. I'm much more likely to try to find a way to do a selective fusion if they need any fusion. But if you're going to even do that, I want to do it right. I'm not going to do something that creates stiffness and creates more risk for that adjacent failure or the PJF. So we can't fix all of those issues, but I think the more we talk to surgeons about, hey, the minute you stiffen something, you better get it right in that alignment, because it's a biomechanical ticking time bomb for that patient if you undermine them.
And then how do you guys, so I know there's 9 of you there in San Diego, and you guys, most of you guys do deformity work. How do you economically survive? Because, as far as I know, again, unless San Diego's, different Medicare payments, I mean, every time you do more than a 1-level fusion, even a 1-level fusion on a Medicare patient, the hospital loses money on those cases. So how do you guys economically and ethically and all those the concerns, how do you survive in our current economic environment?
We're a little privileged in the mechanism or the system that we're in, and that we, number one, only 2 of us really do much deformity. But the group is partners with the health system. And so we try to work with them to be as efficient as we can be. So the losses that may occur on the deformity, we try to help make up, and we're very efficient with all the other care and the deformity care with respect to implants and biologics. So there's a transparency as much as we can engender in terms of direct costs, what we're actually costing the facility, our implant costs, and working to make sure the implants are not a huge loss. So keeping those acquisition costs down. It is a challenging situation, as you said, Ron. I mean, I can't say that we're profitable on all the deformities, but we try to be good stewards and partners with the health system and making sure that our choices are aligned with theirs, and that it's sustainable for now anyway.
Yeah.
Two technical questions, if I may, but please, anybody on the audience, speak up. I don't want to monopolize the questions together with Rod. It's so great to have you, Dr. Eastlack. Technical questions, ALIF versus TPLIF. You mentioned that earlier in your talk. In general, and from your big data review, is there an advantage to encumber the patients with anterolateral surgeries to reestablish a better lordosis relative to TPLIFs? And if so, are there ways to or variables that one can use if one chooses posterior surgeries to have better lordosis?
Yeah, I think that's a bit more of a complicated equation, because I think when you start talking about posterior interbody versus anterior interbody, particularly at L5S1, you immediately have to bring in the risks and the comorbidities associated with those two choices. So in the end, it's all about, let's get the alignment. And so if you do a posterior interbody, it's completely reasonable to do it, but you have to do it. If you do a minimally invasive posterior interbody or TLIF at 5.1, chances are, if they already have a suboptimal segmental alignment, you're going to not get them where they need to be, or they will lose it in the postoperative period through the cage not supporting, and the screws will typically swing a little bit. So that's the attainment and then sustainability of the alignment. If you do an open and you take the facets out, you're doing a bit more of a release, sometimes even bilateral TLIFs, you can generate the lordosis you need. Then you got to go back to the risk equation. Can you generate that same lordosis through a mini open ALIF and perc screws with less overall risk to the patient than an open TLIF with a lot more blood loss? Perhaps. There's no data yet to really differentiate those two, but I think those are the thoughts. And as much as we love MIS, in my opinion, if you don't do it well at L5S1, which probably means doing a takedown of both facets, you're probably underserving the patient in most cases.
Yeah, that's actually yes, confirmation bias, but that's music to my ears to hear that from you, and you know that. The other question I have is, again, I want to pick up on what I said earlier. I see a lot of fusions done that go down to L5, that are multi-level above L5. And in an aging patient, especially a well past or menopause female with a somewhat collapsing 5.1 disc, is there any justification to stop on top of a collapsed L5S1 disc anymore? Or should this just immediately mean to go down to the pelvis or S1? So leaving 5.1 alone and hoping that this quote motion segment survives over time with a multi-level fusion above that, is that a sensible approach, or especially with your focus on lower lumbar lordosis, doomed to fail?
I definitely worry about that. Obviously, there's a lot of wrinkles to that. If they've got an ankylosed 5.1 level or a transitional level that's very stiff, that's a different animal to me, maybe a bit more tolerable. If it's a 2 to 5, it's not a terribly uncommon little degen scoli 2 to 5, maybe that's a reasonable place to be. But if they've got a sort of early degenerative 5.1 level and you're doing more than a 2 to 3 level degen scoli sort of fusion, In my opinion, I think you're probably submitting that patient to a relatively rapid failure and need to return to the OR quickly. And then you're probably better off including it. So there's a lot of spectrum there, but that's generally the way I think about it.
We have time for one or two more questions. Rod, do you have a question? Otherwise, let me ask you another question. I have so many questions, and especially since we have you. One of my favorite topics is overlooked technologies, and that is disc replacements. Let's talk about two motion preserving things. So is it better to have disc replacements kind of be a go-to choice for degenerative disc disease and suitably selected patients? I mean, there are a myriad of factors, as you said, that go into that. But in general speaking, in equal patients, is it better to consider disc replacements rather than having this fusion fixation that we have evolved into, looking at adjacent segment disease, et cetera?
That's a great question, Jens, and I'm going to preface this response with I think we're limited in our data to a great degree because all of the wonderful level 1 data that has come out of disc replacement technology studies that got it onto the market were juxtaposed with fusion models that were probably not accommodative of what we just talked about through this presentation. So the short answer is I don't know that we have the data to represent that disc replacements actually are any better. But in a realm where alignment is not appropriated with fusion, the disc replacement in my mind sort of overcomes the surgeon inadequacy in prescribing that. It allows that level to go to where it needs to be rather than the surgeon creating a kyphotic environment that creates more adjacent segment risk. I hope in time we get more quality data to answer that question, but I still have hope that the disc replacement in the right patients is the right choice. I do worry about the young patient 20, 30 years in and having what we see in total joints and every other realm of orthopedics wearing out and what we do with that group, but I still do them rarely on a really, carefully selected patient because I think there is something to allowing motion and taking out one factor that we create adjacent segment disease with.
Yeah, I mean, music to my ears, and I think we coincide, and especially the focus on lower lumbar, lower doses with L4-5 and L5S1 being such suitable target levels might be a consideration. The other question is interspinous process spacers. So again, motion preservation. This has been a growing market segment, non-fusion procedures. There was a huge amount of concern that they're kyphogenic, that they tilt the spine forward. In your larger scale assessment, has that turned out to be a concern as we've now approximated about 5 to 10 years? And I know there's some device differences, but in the big picture, are they kyphogenic? Are they something that might be a substitute for excessive fusion disease and fusion applications?
I don't think we have the answer to that. I know some of the data suggests they're not kyphogenic, but they certainly are restraining. I don't think they probably allow for the same sort of dynamic nature to the disc. And so while the limited data we have may suggest they're not terribly kyphogenic, mechanically speaking, I worry about that. I don't think that there's a very good likelihood that they can't at least create a situation where there's more shear on the disc in a sense, because it's going to disallow as much dynamic lordotic nature to that segment or compensatory nature to it. So I don't think it's necessarily well known yet, but I have major reservations about them. I don't partake of them typically.
Yeah.
Hey, Rob, Jens, one last question. When you have to do more than 30 degrees of correction, are you still doing PSOs? And I know you know this, but Jens and I, Jens actually more than myself, really has, I think this interdiscal osteotomy has revolutionized my practice. Where you basically go in and do a circumferential, release and put in expandable cages. What are you guys doing in San Diego? Are you still doing PSOs or?
We are. I mean, we do up to
Mhm.
VCRs if we have to. It depends
Yeah.
on where the correction has to occur and how stiff the spine is. I mean, the PSO is still a workhorse if the spine's stiff. If the disc
Yeah.
is open, we'll do exactly what you said.
Yeah.
So and much more rarely now are we doing things like ACRs because of that distribution concern.
Sure.
So if there's deformity of the bone in the upper lumbar spine, meaning erosion, and there's a kyphotic bony segment, that's a great place for an ACR because you're
Yeah.
replacing bony dysmorphic nature and getting lordosis where it was lost specifically. But the answer is it depends.
Yeah.
Real stiff, no disc, PSO all day, bigger correction, VCR, open disc space, intradiscal release,
Cool.
partial osteotomy. Yeah.
Great. Thanks, Rob.
We're at time. Great information. The take-home message for me is every fusion surgery is a deformity surgery, either at the time of being performed or in the future by under correction. Awareness of the great literature that the ISSG and the active participation of Dr. Eastlack and colleagues has produced with great references in this lecture is highly recommended for anybody who does perform fusion surgeries, and very practical, meaningful learning points, and superb discussion as always. Dr. Eastlack, thank you so much. And the late Dr. Jane would smile on your contribution today. So much appreciated.
Thank you for having me. Rod, get well.
Thanks. Thank you so
Thanks
much.
so much. Really appreciate you
Rob.
being here.
Take care.
Great to see you.
Yeah.
Good to see you.